Welcome to It's Your Case, presented by VetCT.com. I'm Heather Chalmers, your radiologist on demand for this week. Today's example is a 7-year-old mixed breed dog with subacute onset of hind limb paraplegia. Here we have just one view, and I'll give you a minute to look at it. I'm going to zoom out to make sure that you can see as much as possible. While you're looking at the lumbar and caudal vertebral, caudal thoracic spine in this dog, I'll mention that for a case like this, the neuro and physical exams and your clinical database are really important. But often we would consider a differential list like intervertebral disc herniation, fibrocartilaginous embolism, trauma, neoplasia, or infection such as discospondylitis. So the role of radiographs in a case like this is usually as a screening tool to exclude a vertebral neoplasia, aggressive lesion, or discospondylitis. Additional assessment in patients with T3L3 myelopathy usually requires cross-sectional imaging, such as MRI or CT. Now that you've had a chance to look at the spine, you've heard me say that I follow the ABCDs approach: alignment, bone, cartilage, devices, and soft tissues. For spine, the alignment piece requires careful review. I want to show you what I do. We only have the lateral view here, but my approach is I follow the vertebral bodies both ventrally and dorsally on all views. I especially look at the alignment of the end plates relative to their neighbors. Any mild malalignment on the radiographs can represent clinical injury such as subluxation or luxation. In addition to looking at the alignment of the vertebral bodies one by one relative to their neighbor, I also look at the overall alignment of the spine, whether it has particular curvature like a scoliosis or a kyphosis, for example. After alignment, I then move in to assess bone and cartilage. For spine, I employ a specific sort of subroutine where I look at bone and cartilage almost together, because what I essentially do, and I'm going to zoom in for this again, is I try to look at key features of each vertebra within itself and relative to its neighbor the whole way along the spine. The subroutine and sequential assessment that I do would include the following: disc space width and margination. So here I'd be looking at the disc space width, and margination would refer to how well defined these end plates are, which for me looks really normal in this case. The next thing that I would look at, once I've looked at disc space width all the way down the spine, I then look at the synovial articulations. The synovial articulations are comprised of the articular processes of adjacent vertebrae. This radiolucent crescent that you see along each synovial space represents a summation of the radiographic joint space. So the next thing that I look at is this radiographic joint space and its margination. Common findings that you might see here could include a little bit of new bone formation, for example, along the dorsal aspect. In this case, I think this is probably just the edge of the vertebrae more so than new bone formation, but it certainly could be very early osteoarthritis. Once I've assessed the disc space and the synovial articulations, I also like to look at the intervertebral foramen width, starting at the caudal spine for this one. Intervertebral foramen presents as a radiolucent feature on the radiograph because it represents a space between the vertebrae where the neurovascular structures exit the vertebral canal. So the space should be well defined. Often people refer to it as having a horse head or a Snoopy sort of head type shape. And you can see that we assess those all the way along the entire spine. The individual opacity of each vertebral bone is also something that I pay attention to. Very early aggressive lesions of the spine can be much less obvious radiographically than what we've seen with limbs. So what you want to see is that the overall opacity of the structures is quite similar for each vertebrae, that one isn't substantially more radiolucent, which could support bone lysis. Lastly, the vertebrae have many different anatomic features, and I try to assess each of them. So this would include things like the spinous processes and the transverse processes that I look at along the way. One thing that I also assess, which is sort of a crossover between when we looked at alignment and our bone and cartilage assessment, is I actually then drive my eyes and use my mouse to go all the way down the vertebral canal. Remember that in a patient with T3L3 myelopathy, we're of course concerned that something could be going on causing compression within the vertebral canal. The vertebral canal margins show up like this, with the dorsal aspect being a very thin sort of white line on the edge of the bone and the ventral aspect looking like this. So I follow those lines the whole way down the vertebral column. So now that I've expressed my subroutine and the details that I look at for spine, I want to point out some specifics in this case that you might have noticed as we were talking along. This is T13 with the last two ribs. Here's L1, L2, and L3. I want to focus on L23 for the rest of our video. When I think about my subroutine, one of the first things that I look at is the intervertebral disc space width. I would argue that this disc space width, so the kind of cranial to caudal or the width of it, is reduced compared to the vertebrae in front and the vertebrae caudal. The best comparison for spine is always going to be the adjacent vertebrae. In addition, when I look at this disc, it has increased opacity. This is the appearance of partially mineralized intervertebral disc. The next thing that I see at this site would be when I move along my routine to look at the synovial articulations. That crescent-shaped radiolucent joint space here at L12 is larger than what I see here at L23. It's also L23 slightly smaller than what I see here at L34. This is another sign that these two vertebrae are closer together than their neighbors. The disc is narrow and the joints are more narrow. Another thing that I notice is that snoopy or horse head. When I compare the intervertebral foramen here to here, this one here at L23 looks more narrow to me, especially when we compare to L34. So taken together, narrowing of synovial articulations, narrowing of the disc space, mineralization of the disc, narrowing of the intervertebral foramen, without any evidence of an aggressive process or discospondylitis elsewhere, I would be very concerned for intervertebral disc herniation at this site. Whether this is an acute thing related to the current signs or a chronic thing that is not of current clinical relevance cannot be determined accurately from radiographs. I would then suggest, depending on clinical signs, MRI or CT examination. Be sure to review the full report associated with this case. Thanks for listening, and remember, it's your case, so please post your questions on social media.